Good afternoon, everyone. My name is Lőrinc Ulmann, and my PhD thesis title is on the new insights on the prognosis of pancreatic ductal adenocarcinomas. I am a PhD student and a surgical resident here at Semmelweis University Department of Surgery, Transplantation, and Gastroenterology. My supervisor is Akor Such, and my SMS is Mahmoud Obeidat, and my vision is to be able to combine research and knowledge in the surgical treatment of pancreatic cancer. And in order to achieve this, I am planning to research how the different pancreatic tumor mutations lead to a different prognosis. I have two ongoing projects, so I have two specific goals with these, and I will present each of them at their own slides. So my first project is about investigating the prognostic relevance of micro-RNA analysis of pancreatic ductal adenocarcinomas. This will be a systematic review and meta-analysis. So in order to introduce the topic, one has to know that PDAC, or pancreatic ductal adenocarcinomas, is one of the worst prognostic cancers in the world, with a 5-year survival rate of around 7%. And so what do we tell the patient? Is this only a homologous disease? Well, one possible solution for this could be micro-RNA analysis. These are small types of nucleotides that affect the development of PDAC as acting as either oncogenic microRNAs, tumor suppressor, chemotherapeutic resistance-related metastasis, or multifunction microRNAs. Thus, my aim with this project is in order to investigate the prognostic relevance of microRNA analysis in PDAC. My population are patients diagnosed with PDAC. Prognostic factor will be measured in the high and the low microRNA expression levels, and the outcomes will be measured in overall and disease-free survival. And my clinical implication for this could be detecting the different survival rates of pancreatic patients. We have conducted a systematic search in 3 different databases. We have added 3 different domains, with the first one being microRNAs, the second one about pancreas, and the third one being the cancer type. You can see our flowchart of selection here. We have started out with 11,000 articles and then end up with 148 ones. We have just received our final data on the 27th of December, so we have divided up our analysis into these subgroups, these 6 ones: oncogenic, tumor suppressor, metastasis-related, chemo-resistant, and dual-role microRNAs. The less studied microRNAs we have not analyzed. So, in order to present my results, I will first be talking about the single-arm results of each subgroup, after that the univariate and multivariate results of the overall and disease-free survival, and lastly a note on microRNA 21. First of all, you can see the effect of oncogenic microRNAs on the overall survival of PDAC patients, and you can see that if they were less expressed, then the median survival times are much greater than the ones where they were highly expressed. Second one is about tumor suppressor microRNAs. The trend is the same, but they don't have that much of a significance on there. The third ones are chemo-resistance-related microRNAs, and they have the same exact results. And lastly, the metastasis-related microRNAs. In there, it's the exact opposite, where higher expression being a greater survival time. After this, I will present the univariate overall and disease-free survival results. As you can see up on this forest plot, the overall hazard ratio for this group would be 2.56, and you can see that this was statistically significant. We have even researched which type of chemo-resistant agent they have used. In all of these articles, they take a mention of neoadjuvant or adjuvant therapy. However, only in these articles where they were actually presented which type of agent they have used. After that, you can see the univariate overall survival result analysis of dual-role microRNAs, which was also statistically significant, with a hazard ratio of 1.78. And after that, the disease-free survival of analysis of oncogenic microRNAs, which was also significant. In this case, even though we have statistically significance, however, the small number of articles only show a trend for this. And this was for the metastasis-related microRNAs. Next, moving on, you can see the chemo-resistance-related microRNAs with univariate DFS analysis with a hazard ratio of 2.70, which was also significant. And lastly, the multivariate analysis for the chemo-resistance-related microRNAs for the overall survival, which was also statistically significant. Further on, in this one, it was not statistically significant because only 3 articles were presented in this case. And the multivariate overall survival analysis of oncogenic microRNAs, same case in here. And lastly, a note on microRNA 21. We have determined that statistically this is the most accurate microRNA which could represent the prognosis of these patients with a hazard ratio of 2.37. So we have our strengths and limitations of this study, with strengths being that they do show statistical significance in the overall and disease-free survival groups, and they do add a great amount of studies that we have involved, and they do provide information about the possible chemoresistance. But there are some limitations, being a heterogeneous population, because there were many subgroups that we have included, and we don't know the exact pathophysiological pathways behind these. And also, we have not only included RCTs, which is why there's further investigation necessary. So as a conclusion, microRNAs, particularly microRNA 21, they do hold a significant prognostic value for patients suffering of PDAC. Our implications for practice are predicting disease prognosis and chemosensitivity, and they could be a part of improving personalized diseases management strategy. Our implications for research would be standardized serum level test, researching the sensitivity to individual chemotherapy agents, and optimizing disease management protocols. So you can see our current status here. We have written our manuscript right until the discussion, and we will be sending it out for internal review. And our the journal that we will be submitting is International Journal of Cancer. You can see our progress here. And I will present now my second project, which is about comparing the prognosis of patients treated with borderline resectable pancreatic cancer receiving neoadjuvant therapy or upfront surgery. This will also be a systematic review and meta-analysis. In order to introduce the topic, one has to take note of the treatment protocol of pancreatic cancer, because basically surgery is the only chance of survival, but only 15 to 20% of these are actually resectable. If there's no resection done, then the 5-year survival rate goes down to 7%, but with resection it increases up until 15 to 30%. In the borderline resectable group, this also represents a significant amount of addition to the survival of patients if it's resected. Thus, our aim is to compare the effect of neoadjuvant therapy and upfront surgical resection on the prognosis of borderline resectable pancreatic cancers. And also, one has to take a note on borderline resectability, because the therapy is defined by 3 different categories: biological behavior, the radiology, which determines surgical resectability, and the patient performance status. Thus, with this project, we need to consider short and long-term survival rates. We need to compare the cost and benefit analysis of neoadjuvant therapy and upfront surgery, and we need to determine which patient population should be considered for which type of specific therapy. So, our population in here are patients with borderline resectable PDAC undergoing neoadjuvant therapy. Our interventional groups are preoperative neoadjuvant therapy, and our control would be upfront surgery, and we will be measuring our outcomes in overall disease-free survival, percent of operability, reoperation rate, R0 resection rate, and the post-operative complication rates. We are hypothesizing that neoadjuvant therapy is safer and more effective in the treatment of borderline resectable pancreatic cancer than primary surgical resection. You can see our flowchart of selection here. We have started out with 1,500 articles, and we have ended up with 4 eligible full text. You can see our progress here. The data extraction will be done by the 30th of January. And as a summary, I will be planning to submit my first project in February and my second project in March 2025, because it's a way smaller project. To end my presentation, I will be ending it with a quote from John D. Rockefeller: "If you want to succeed, you should strike out the new paths rather than travel the worn paths of accepted success." Thank you very much.
Thank you, Lőrinc. I would like to ask the audience if there are any questions.
Yeah, congratulations. So regarding to your second project, So what kind of neoadjuvant therapy would you like to include? So all type of neoadjuvant therapy with radiation, or only one type, or what is, because there are different types and different regimens.
You mean for this, thank you for your question, you mean for the second project, right?
Yeah. The second.
We're including both chemotherapy and radiotherapy because we have only included articles which actually do compare neoadjuvant therapy to surgery with at least one group. So yeah, chemotherapy and radiotherapy. And in there's one instance with immunotherapy too. So yeah.
Thank you.
Congratulations. My question is that what was, for the first project, what was the tissue sample, what kind of tissue samples did they use for the micro-RNA isolation?
Thank you for your question. It was both serum and tumor tissue, and in our full result list, we have even determined in which article and which was used. So it does represent a heterogeneous population because of that too.
And any chance if you use subgroup analysis for differentiating the both group, the resection material and the circulating tumor cells?
Well, we could do that, but since we had such a great amount, because we had more than 250 microRNAs that we have analyzed, and in most of the articles it was not mentioned which exact tissue type they took it out. So we could compare them, but for instance, if we go back to microRNA 21, you could see that huge table up there, and not all of them have they mentioned which sample they have taken out exactly at which patient, which is why we were not able to statistically compare those two into subgroups.
Congratulations. Do you work in everyday clinic?
Yes, I do.
All right. Have you presented your first project's result to your boss?
No, this is actually my first presentation because I just received these results.
All right. So my question is useless. Did you implement it into your everyday practice?
Well, we would like to further investigate these microRNAs, and we have a currently ongoing project which we're actually planning to analyze the tumor samples and the serum samples taken from these patients with PDAC and do a new project on that. So yeah, eventually we would like to do it in the clinical practice.
It's just a suggestion or advice that you have at least 4 figure slides with the same main title, meta-analysis.
Yeah.
And it does not add anything, so I would suggest to choose a more precise title for your result slides.
Thank you, I will do so.
Lőrinc, what or how are these measurements available in Hungary? Are they available, or what about the personalized treatment? So first, are the measurements available, and then what about the personalized treatment?
Well, they are available at a cost, so they are not stately financed, so they could be available, but what we are conducting right now is that we're trying to include immunotherapy, which could actually be determined by the microRNA levels expressed there. So, I mean, it could be available, but it's not yet available in the everyday practice. But on a research level, it is, yeah.
Okay, thank you.